So hello, everybody. Welcome. Thank you for joining us today. This is our second training of the day. So if any of you think I look familiar, yes, you were with me earlier in the day. So if you are coming back, I thank you. I applaud you. It's a little later in the day for you all to be sitting through another training. So I'm hoping that this one you will find interesting and a little different because I know that none of us probably receive as much training around sexual health as we need for us to properly be able to meet our clients' needs and serve our clients and also have a better sense of comfortability in addressing these issues. So I welcome you here and really glad that you're here with us. My name is Dawn Reinhardt Wood, and I am joined by my colleague Jennifer Sperduto from Rutgers University School of Health Professions, Department of Psychiatric Rehabilitation and Counseling Professions. So tonight we're going to be talking, this afternoon, we're going to be talking about sexual health and recovery, and this is part one of a two-part series. Today's webinar is being hosted by DBHR through the Healthcare Authority. This is an interactive training, and we definitely encourage you to ask questions and interact throughout the session. The slides, as well as a link to the recording of this webinar, will be available in the follow-up email coming from Washington DBHR after the presentation. So probably at some point by the end of the week, you'll receive it. The other thing that I wanted to, yes, Jen.
I was just gonna say, I'll be manning the chat. So if you had a question or a comment, or you want to participate in the discussion, you can type something in the chat box. Make sure it says to everyone. You can change it from hosts and panelists to everyone. That way everyone can see your question, unless you specifically want it to come just to Dawn or me. And then if you would like to speak, if you don't want to type, just raise your hand on the next to your name. You can raise your hand and then I can unmute your mic and you can speak. So either way is fine with us, whatever you prefer.
Yep. Thank you. Jen basically just covered this slide, but just to reiterate.
I'm sorry.
No, it's okay. It's okay. I tend to do this and then I hit this slide, and it's good. It's become second nature for us just to say it. At one point, we needed reminders because we were so new to Zoom. Just a reminder that everybody, you're muted when you come in and your cameras are off. Those are just the webinar settings. Like Jen said, to ask a question, do what Jen tells you to do. That's always a good rule. You can just open the chat, pop in your question, or raise your hand from the participant list. We like questions to come in as you think of them, because I really think that it adds a dynamic nature to the training, rather than me just sitting here behind my computer and talking and not knowing if anybody is engaging with the material. So we love that. Yep. And like I said, feel free to ask questions as they arise, or if you'd rather just save them for the end, that's fine as well. If we have time at the end of the webinar, we'll hang out for a little bit. So just to introduce myself, and I'm not going to read this entire screen. Again, my name is Dawn, and I'm one of the faculty here at Rutgers University, and I'm on a team of embedded consultants that work with the state psychiatric hospitals around training, research, and technical assistance for evidence-based practices and their role in an inpatient environment, again, in the state psychiatric hospitals. But I have experience, most of my experience was working in the community and community mental health programs, primarily supportive housing and homeless outreach. And I'm joined by my colleague, Jennifer Sperduto, who has a similar work history, lots of experience in the community, including very psych rehab focused clubhouse model type programs, vocational rehabilitation, and community housing programs. And she is also on the team of embedded consultants, providing technical assistance, consultation, and training to the state psychiatric hospitals.
Thank you.
You are special, Jen. So welcome, and let's talk a little bit about what we hope you will acquire as a part of this training. At the end of the webinar, we're hoping that you'll be able to basically define sexual health, realize the comprehensive nature of that definition and all of what it means and why it's so important to begin to sensitize ourselves to this topic and become comfortable in talking about this aspect of our service recipients' lives, because you will see, you know, how this area of our lives as human lives is so impactful on our overall well-being. We're going to discuss the impact of stigma on sexual health and wellness, identify sexual health risks for people with behavioral health conditions, and identify some initial strategies for supporting the sexual health of the individuals that you might be working with. Because this is a two-part series, I decided, you know what, I'm going to save more of the strategies for part 2. And so we'll have a little bit more time in that part, which will be next Wednesday at 2 p.m. to get more into some of the techniques for engaging individuals and talking about sometimes hard to have conversations. And I want to acknowledge the fact that talking about sex has never been easy, especially in the United States. So, and we've been taught a lot about maintaining boundaries and why that's so important. And that can become challenging when we start to address these issues. And so we will devote a lot of time to that next week. So this week, really just kind of providing you with some information and overall getting your feet wet and comfortable and able to identify some of these issues that are encompassed by when addressing sexual health. And sorry if I'm stumbling over my words a little bit. This is the second training of the day and it's been a long day, so thank you. So I just want to start here at this slide. And I want you to think a little bit about if you've ever had a romantic relationship. And when I talk about sexual health, romantic relationships, dating, marriage, those sorts of things are just one aspect of it, right? But for a lot of but it typically tends to be the ultimate goal for a lot of the individuals that we work with, is to find someone that they can partner with, that can support them, that they can share their lives with. And very often, I know as a supportive housing case manager myself, as somebody who did a lot of work in the housing realm, that is something that I would hear. And my goals and priorities and what meaning the state of New Jersey, funders told us was the goal of our program was really around keeping people alive, out of the hospital, hopefully free from drugs and alcohol to a point that it impairs their functioning, and to keep folks housed, right? So I really didn't think about this aspect of individuals' lives for many reasons when I worked in that setting. But I want you to think a little bit about what positive romantic relationships have done, perhaps in your lives, in lives of people you know. And if you can, just pop in the chat or raise your hand and I'll give you the mic. What are some of the things that you think about when you think about a healthy, positive, again, healthy and positive romantic relationships, and the things that brings to a person's life in terms of improving the individual's life?
We have open communication, stability, confidence, trust, support, affection.
Yeah. So all kind of along the lines of my gut instinct, right? So this screen is my gut instinct. This slide is what I think about when I think about a healthy, positive, romantic relationship. And that is that, hopefully it's founded in the basis of love, and that there's mutual love, and there's things that go along with that, right? Respect and other things. There's support. So a lot of you have talked about that in whatever ways, if you're talking about encouragement or somebody to rely on, even practical things. Like one of the things that happens when you partner with somebody legally and officially, in a legal and official way that's sanctioned by our government, and it's funny that I have to say that, but I do, you get breaks, right? You get tax breaks. you get credits, you get, when you partner with somebody, even if it's simply in a roommate type situation, you're sharing resources, right? There are benefits that come along with that that aren't just based in love and sex and romance.
There's
And so
also things coming in like intimacy, affirmation, not an antidote to loneliness, security, togetherness, contentedness, connection, like all of those things.
I love the antidote to loneliness.
Yeah.
That's beautiful. Yeah. And so like I can get really gushy when I start talking about this stuff. And this is part of why it's an area of interest for me, because we all know what it feels. I hope we all know what it feels like that at some point in our life, to have had that really good relationship with somebody. I'm not going to say perfect, but I'm going to say a relationship that felt very reciprocal, where we felt supported. May not have been a romantic relationship, right? But that type of really quality relationship that you have with an individual, where you know that you can rely on them and they help you grow, and being with them like makes you exponentially better. And that's obviously what we're striving for. So it's really cool. I think that people tend to coalesce around these three areas of love or romance, support, growth, intimacy. So you see, having these types of relationships and aspiring to these types of relationships, not only does entering into them and having them bring a lot of wonderful things when they're working well, but there are also a lot of things that people with behavioral health conditions, can utilize for forward progression in their recovery, right? Having that cheerleader, having the ability to practice communication skills. A lot of us find out once we're in a relationship that our communication skills aren't so great in that specific setting, right? In the romantic setting, you might be able to communicate with your coworkers, with other people who maybe you don't have as much of an emotional investment, but it's just a little bit more difficult there. So these types of relationships can also highlight areas where people may identify or may need to identify other areas for growth and honing and skill development. Thank you for that little exercise. So now that we've defined what love and having a healthy sexual relationship means for us, let's look at the bigger picture of the actual definition, the global definition of sexual health. And this comes from the World Health Organization, and they say that fundamental to the overall health and well-being of individuals, couples, and family, and to the social and economic development of communities and countries, that is how essential sexual health is. And when you think about it, yes, it is, right? When you think about areas that have been devastated by the onset of sexually transmitted infections like HIV, and reproductive tract infections, which isn't talked about that much, that can affect population growth, right? There can be very real devastating effects to a society not being sexually healthy. And so we're going to look at some of those challenges of sexual health, and some of the other areas in which attention needs to be paid to them. Sexual health also requires a positive and respectful approach to sexuality and sexual relationships, as well as the possibility of having pleasurable and safe sexual experiences free of coercion, discrimination, and violence. So sexual health isn't just about the act of sex. It's also about how people, define what it looks like for them, how people identify. And we will talk about gender and affectional status. And if you aren't sure what that means, I use that term, and it's starting to become used more and more and more, affectional status, because we used to talk about same sex, or I'll just say not heterosexual relationships as homosexual, right? Or same sex relationships and these sorts of things. We like to sometimes use the term affectional status because at the heart of the relationship, it's about who you love, right? Who you are drawn to, who you are loved. And it's not just about the sexual act, period. But we will talk more about that in part 2. But one of the foundations of trying to create a sexually healthy society is to respect and be positive towards the topic of sexuality and sexual relationships, which can be difficult and challenging in a historically puritanical society like ours. It's why most of the research that I read comes out of the Scandinavian countries, because they have a much healthier approach and belief about sex. So why is sexual satisfaction and being happy with our romantic relationships important in psychiatric recovery? Does anyone want to take a guess? The arrows might help you. Maybe not. Okay, so I'm not sure if that was a older comment, but I saw somebody say connection. And so connection is extremely important in the process of recovery and in having intimate relationships. One of the things that has been discovered in researching this topic is that as individuals rate their, or when asked to rate their level of psychiatric recovery, individuals who state they are further along their path in psychiatric recovery tend to also be more satisfied in their intimate relationships. And vice versa, individuals who state that they are more satisfied in their intimate or romantic relationships tend to say that they feel like they have achieved a greater level of psychiatric recovery, regardless of the condition that they are recovering from or living with. This doesn't seem like rocket science, right? If we're happy in different areas of our life, we may be more happy overall. And if we're functioning better psychiatrically, behaviorally, we're probably going to be doing a little bit better or doing pretty well in the other areas of our life. So this relationship is a bidirectional relationships. The better that we're doing, the better that we're feeling in terms of managing our mental health condition, behavioral health condition, dependencies, whatever they may be, the overall, the better our romantic and intimate and other relationships in our lives are going to be. And vice versa. And it's because a lot of these skills that are necessary in achieving recovery from behavioral health conditions are also integral in maintaining relationships with other people. We talk a lot about social skills training in the world of psychiatric rehabilitation and in serving in serving behavioral health participants. And I think we don't think about how much those teaching of the social skills cross over into other areas of our life. The other areas of how to manage with our own or one's own symptoms of a mental health condition can really help us in problem solving and resolving, kind of conflicts in other areas of our life. And so, we really need to think about how when we have clients who identify having a significant other as their overall rehabilitation goal, and I don't know if any of you have ever had that happen. It happened to me a lot when I was a case manager, and it was one of the reasons why I started developing a lot of interest in this area. I would present what I thought was a practical goal, and again, you see the flaw in that logic. I was presenting the practical goal to the individual that I was working with, and I'll try to defend myself and say this was almost 25 years ago. But that's kind of how things were done, right? We would say, okay, we're working around your housing. We're working to keep you well and out of the hospital. And automatically, not just myself, but a lot of the service participants that I worked with would think of the traditional things. I want to, keep going to program. Maybe I want to think about working. I want to maintain my apartment. But there wasn't a lot of depth to that. And every once in a while, somebody would say something like, I want a girlfriend. I want a boyfriend. I want a woman. That was something that somebody said to me. I want a woman. Can you help me get a woman? I said, I can't quite help you get a woman. But once I kind of processed my own discomfort with that, I was able to figure out how I could use that desire for this overall rehabilitation goal, and a wonderful one at that, to have a relationship to also benefit the individual in other areas of their lives and to build the momentum for some real, especially skills growth. So the individual that I'm referring to was very, we'll say treatment non-adherent. I don't like the word non-compliant. They just weren't quite ready. Used a couple of substances, alcohol a little too much. Would I say that they had a dependency? No, but probably partook a little bit too much. And it got in the way of things. It got in the way of them attending to their mental health. It made their mental health symptoms worse because the things that they were using were depressants. The things that this individual complained about a lot, these things were getting in the way. One of the reasons he wasn't able to meet people that he was interested in is because he only felt comfortable doing that if he was intoxicated. But when he got intoxicated, he didn't feel like going out. And he also got a little self-conscious about talking to people that he was interested in because the alcohol could make him a little bit more loose-lipped, right? So it really helped us hone in on, well, what are the things that we need, that we all need to have, the skills, the resources that we need if we want to partner with somebody. How do we develop those? How do we acquire those? How do we address those in such a way that it's not only helping us towards that overall rehabilitation goal of having a partner and getting married, but it's also helping along the way in general recovery, right? So if we can get an individual to cut back a little bit or to start thinking about maybe their substance use because it's getting in the way of them getting out and meeting people, or it's getting in the way of them going to work. And if you want to meet somebody, you might want to have some things to talk about. And a lot of times, one of the first things we do when we meet a person or we're interested in somebody is we say, what do you do? And in this individual's case, he didn't want to say, I'm at home and I'm on Social Security disability. I don't do anything. And that was really painful for him. And so one of the things that we did was we were working on some vocational goals as well, not only to have that sense of meaning in his life and that he could talk to another individual about something that gave him pride and joy and a purpose in his life, but now he also has a little bit of funding in his pocket to be able to court a person. And yes, I'm using old-timey words, but these sorts of things that we don't always think about when we're not an individual in recovery from a serious mental health condition. There are plenty of things that get in the way of positive relationships, positive romantic relationships. And for individuals with behavioral health conditions, it can be even more challenging because of the fact that they may be outside of that, social network and outside of the kind of center of society in a lot of ways because society kind of pushes them away. So we're going to talk about some of those stigmas that surround individuals and why they may be separated a little bit from kind of even the world of dating and the world of social connection. Jen, did you want to say something?
Yeah, just before you move on, Tanya had a question.
Yes.
How does this tie into the circles of sexuality with regards to the understanding of sexual satisfaction and recovery?
Sexual satisfaction and recovery. So sexual satisfaction, and let me see if I can answer your question. And if I don't quite answer your question, it's because maybe I didn't understand it a lot, quite to the degree I needed to. So I might come back to you with seeking some clarity. So sexual satisfaction, people who are at higher levels of psychiatric recovery self-reported levels of psychiatric recovery. And there are tools that we use to measure this. Report greater levels of sexual satisfaction. People who report greater levels of sexual satisfaction report being happier, report advanced, what I would say, advanced scores on recovery measures. So even people who may not be in the world of, psychiatric treatment or treatment for mental health conditions, individuals who may not be identified as someone or identify themselves as having a behavioral health condition, report greater happiness when they are sexually satisfied. So when we say sexual satisfaction, it is not just the act, the consummation of sex and the sexual relationship. It is also all those other factors that go along with sexuality and sexual health. So being comfortable with who you are as a person and who you love and who you identify, what gender you identify as, your gender expression also, right? So there's a lot of different facets to what makes us satisfied as sexual beings. And maybe that's how I should have phrased this. Being sexual satisfied as a sexual being is also connected to where we are at with our overall wellness. And if we are in recovery with a mental health condition, where we are at in our recovery. So the science has kind of shown that to be true, but it's in its really early stages of research. Exploratory, we call it right now. And that's why people like me and hopefully other doctoral students will continue to research this area, because it really is a baby, teeny tiny infant research area at this point in time. I don't know if I answered your question. If I didn't, please feel free to follow up with another question.
She did say thank you. I was thinking that's what you were saying, but just needed some clarification.
Okay, not a problem. And I will say, as I noted earlier, it's been a really long day for me. So if there's something that I skip over and don't address thoroughly to where you're able to receive the information, please let me know and I will stop and review. Okay, so thank you. Sorry, just trying to find my cursor. So we touched very briefly on this idea of stigma and how individuals are kind of pushed to the fringes of society when they are in any way perceived as different. This is not limited to mental health, having a mental health condition. We know this, right? There are a lot of different characteristics that people have that they're born with, for which they are segregated from our society. And our society has a long history of doing this. Most societies do. And unfortunately, mental health is one of the areas where individuals are cast out, are segregated. And this practice started in our country even before it was a country, when it was a bunch of colonies. We started segregating people and sending them off to places because of not being good fits for society, as we saw it at the time, which was a very puritanical society. And individuals were sent to institutions, to asylums, as they call them, for reasons that weren't at all related to behavioral health, right? So, there is a list of admitting diagnoses that I came across in the state psychiatric hospital, one of them that I was based in here in New Jersey. And it just reviews the entire, about 200 reasons why people were admitted. And this was in the 1800s, when 1848 was when our first psychiatric hospital was built here in New Jersey. Things like, change of life for women were reasons to hospitalize them. Barren was a reason to hospitalize somebody. Low tolerance for the family unit was one that I saw. So, and of course it was the female who was sent away. So it was mom had a really bad day and couldn't take this anymore, and probably had more than a few really bad days. So she was sent off to an asylum, right? So, that woman who spoke out, folks that just don't quite fit and conform to society have been cast out. And so, like we say, unfortunately, this is still present in our society. So one of the reasons why individuals with behavioral health conditions may find it so difficult to form relationships in general with other people is this thing called illness identity. So if you've ever heard people talk about other people by their illness, by labeling them as their diagnosis, right? You've heard people talk about this person is so bipolar, or this person is a schizophrenic, right? And our society has become kind of we're becoming more sensitized to that, but that language is left over from a medical model of treatment, right? When you go to the doctors and you seek treatment for diabetes, you probably don't feel really uncomfortable saying it's because I'm a diabetic, right? It's a little less stigmatized, a lot less stigmatized than being somebody who receives treatment for a behavioral health condition. And unfortunately, that is the case. So it's this adoption of the illness as our identity is what we talk about when we talk about illness identity. And what that does is it spoils our identity. So if I identify as depressed and anxious, and that's how I go through my life, depressed and anxious and somebody who's prone to panic attacks, right? I don't know who really wants to be around me because it doesn't tell you a whole lot about me. It just tells you about this aspect of myself or a couple aspects of myself that I've dealt with for almost 40 years now. But it really doesn't tell you about me. You don't get to know Dawn. You don't get to know the person, just one aspect that they are dealing with. And if you're living in a society like ours and you hear only negative things or predominantly negative things about individuals who have behavioral health conditions, that starts to shape that individual into a spoiled identity. And we can do this to ourselves. It starts from the outside with outside messages, stigmatizing messages. And eventually it becomes an internalized stigma. And once that stigma is internalized, it can be more detrimental to an individual and their forward progressive recovery than actually the experience of the psychiatric symptoms alone. In a study that's about 3 years old at this point that I participated in around vocational involvement of individuals on assertive community treatment, individuals who are receiving services from assertive community treatment teams or ACT teams in the community, which are a nationwide approach to serving people with serious mental health conditions who have had frequent institutionalizations. The thing that we found most predictive of an individual's involvement in vocational activities, whether they were just thinking about it, whether they were maybe starting to volunteer, maybe they thought, you know what, I'm going to get some more education before I enter the workforce. The thing that predicted that was the strongest predictor, was how deeply an individual internalized the stigma that was coming at them about their mental health condition. So the individual who identified with, or, adopted that illness identity was less likely to be involved in the workforce than an individual who was having psychotic symptoms like hearing voices, seeing visual hallucinations, profoundly depressed. Those were less of predictive factors than actually somebody who has identified as, their mental health condition. Does anyone want to take a guess as to why that might be? I was very shocked when we found that. Harold, as people might be typing in the answer to that question or offering up an answer to that question, yes, sexual satisfaction can also include celibacy. So, and I love these questions because there's so much to say about the topic that I may glean over because it's a very deep topic. So when we hear the term sexual satisfaction, we think, okay, it's free of dysfunction. The individual is able to initiate the act, feel pleasure, complete the act, and feel satisfied as a result. Some people are asexual or adopt an asexual lifestyle. Some people adopt a celibate lifestyle for a period of time or for a prolonged period of time. And that is okay. it is about that individual being satisfied in this area of their life that involves intimacy, because it is also possible to be extremely intimate and to be in a positive relationship with somebody and for it to be romantic without this, what we think of as the sexual act taking place to quote unquote consummate that relationship. So I really thank you for that question, because that's also a topic that I love to talk about, that the actual physical act of sex does not have to be involved. And there are a lot of people that physical act of sex, it doesn't happen for a number of reasons. Some of it may be a choice or for spiritual reasons, and some of them may be functional impairments, right? There are issues with medications that are prescribed for people for a variety of conditions, not just behavioral health conditions, that can have a profound impact on someone's sexual functioning. Even medications for things like hypertension and diabetes can cause such side effects. So thank you. So why do folks think that adopting that spoiled identity or believing that I am my illness might be more of a negative hit for me in being able to achieve not only relationship goals, but getting into the workforce or having friendships in other areas of my life than it is actually experiencing symptoms of the mental health condition? Thank you, Becca. I love that. Yeah, absolutely. So when we think we are defined by our illness, or when we start defining ourselves by our illness, sorry, half of my body keeps getting chopped off by my green screen background here. It lowers our self-efficacy, right? I am this thing, and I hate saying it like that, but these are the nasty, dirty thoughts that we tell ourselves. I am this bad thing. I am defective somehow. Therefore, I cannot do this, right? And also sometimes, there's always a little bit of self-doubt in people, not for everybody, but if you're like me, sometimes you question your abilities, and it's just because you want to do well, right? And you're like, oh, can I really be a professor? Can I really do that thing? I still feel like an imposter. A little bit of that is healthy, but to be completely devalued and to have been a part of that yourself by, participating in that process, it's really taking you out of the game and feeling as if you have no agency or self-efficacy. Absolutely. And so also, being labeled a psychiatric patient, and there's a reason why we try to avoid the patient word a lot. For Jen and I who consult with psychiatric hospitals, we sometimes let the word patient slip because that's our world. But we, it is a very loaded term. And so, yeah, Harold, you're saying that it becomes a pervasive belief, right? So not only does that identity get applied to your, we'll say, your mental health world, right? And how you're feeling upstairs in your brain and your body, but also it really does start to change some of the pathways in your brain. Having a behavioral health condition can be a traumatic situation. The loss that is experienced along with being hospitalized, or I don't want to say simply, but simply experiencing a physical condition that robs you of your cognition, that can challenge your perception, that can cause you to question sometimes whether things are real, whether some things are not, whether you should even be on this earth anymore. And let's face it, certain mental health conditions can do that, especially without treatment or delayed treatment. This becomes pervasive. And trauma imprints on our brain. Raised cortisol levels, which is the stress hormone, can change our brain over time, can make it harder for us to think more healthy. And these higher cortisol levels can also change other physiological pathways and functions and mechanisms in our body. So just the stress alone that comes with having a mental health condition can also impact our sexual functioning as well. So the illness identity makes this challenging. Intersectionality can also exacerbate the level of stigma that an individual, or intensify the level of stigma that an individual experiences who has a mental health condition. So consider the individual who, let's say, is living with schizophrenia, or is living with bipolar disorder, also identifies as transgender, and also maybe a person of color, right? So that individual in our society and in many other societies are getting hit with stigmatizing messages over the course of their life. It may not be constant, but over the course of their life, that can further impact or can further push them out of the areas of society where they need to be embedded in to get some of these other goals, or to achieve some of these other goals, right? Like the lack of social connectedness will then happen. Being disengaged, being not included or asked to be included in certain areas of society, and to be actively excluded, and to see messages, to hear messages that are telling people you are not wanted. We cannot disregard how intersectionality can play an impact. So I got a great question from someone privately. How do we heal from cortisol's impacts on the brain? My goodness. I should call one of our colleagues in here she could do a whole lecture on that. I am not the trauma expert, and what you're talking about is the traumatic impact on the brain. But some of the things that we know that can help, and what you're talking about is resilience, right? So building that resilience from the cortisol dumping and that constant cortisol flood that can happen, an adrenaline flood. It's not just cortisol. And then the synergistic effects, the compounding effects that happen when all those neurotransmitters are flooding our system for years on end, decades for some people. It can, the negative effects can be reduced. Can they be 100% ameliorated? I don't know. I'm not enough of, I don't have enough knowledge in that area to be able to answer that. But restorative practices like meditation, and I am somebody who I have never been able to meditate, but I always start with meditation because that seems to be very popular for people. But anything, any kind of activity that you can engage in that can reduce your stress level at any point in your day, whether it's for 5 minutes, whether it's for an hour, whether it's coloring, whether it's meditating, whether it's spending that time with a person that you really like, those sorts of things can help to start to reverse and reduce some of that damage. And you gave me an excellent idea for future training. So thank you, Oliver. I appreciate it. So another area and ways that people with behavioral health conditions may be stigmatized, and it may make it difficult for them to partner with people, is being perceived as violent. I know that probably, I'm going to assume the majority of the people in this room don't think that way when we are, meeting with somebody with a behavioral health condition for the first time. It's just, because we meet people that we don't know all the time, and because all of you probably, like me, go out and you do your business, which is caring for people and providing services to people out in the community, you're always concerned about your safety. But it's not necessarily because the individual that you are working with has a behavioral condition. It's because you're going into somebody else's environment and you're going into communities, and you just always have to be mindful. But for individuals with behavioral health conditions, they have been labeled throughout society, throughout history, as violent. And so this is also another thing that individuals have to think about when they're considering relationships with others. How are they going to be perceived, right? We all worry when we're searching for that special someone or looking to develop a relationship. How am I going to be perceived? Is this a person going to like me? Am I interesting enough? Am I pretty enough? Am I whatever, but then to also be perceived, I don't think that most of us consider we may be perceived as violent. But this is a thing that people with mental health conditions talk about, especially individuals who have been institutionalized or maybe interfaced with the forensic or criminal justice system also. So there's this fear of being judged for a lot of reasons. And the perception of being flawed. And we touched on that when we talked about the illness identity, right? How hard must it be for an individual to think of, well, what am I going to say to this person that I'm interested in when they ask me what I do for a living? When they ask me if I went to college? When they ask me, what is my family like when I'm isolated from my family of origin, right? So there's a lot of challenges that go along with, and having and living with a psychiatric condition that people have to think about, and have to think about, how do I disclose this information, right? So for me, as an individual living with what I would say people probably generally see as, I don't want to say acceptable, I don't think that that's the right word, but very common mental health conditions, depression and anxiety, we probably, especially over the last couple of years, if we haven't experienced those feelings ourselves to a clinical level, we probably know someone who has, because it's been a very stressful few years, right? But for individuals with even more functionally impactful conditions, such as schizophrenia and schizoaffective disorder, bipolar disorder, which are more likely to result in individuals being hospitalized and having years of their life sometimes taken from them, how am I going to disclose to somebody that I have this condition that we have seen in society has been so poorly received, right? And so for me, in my growth and learning how to develop romantic relationships, and was, how do I disclose that? For me, that was the most challenging part of living with a behavioral health condition, was knowing, as someone who works in the mental health system, what people think when they hear the term mental illness, which is why we try not to use that term as much anymore, but what they think of when they hear that somebody has a mental health condition or behavioral health condition. It always made me nervous, because I saw what my clients faced in terms of stereotyping and prejudice, and stigma. And so, that ability to develop a skill around disclosure and boundaries, for me, was a skill that I had to develop with my therapist, like within the last few years of my life. And I was married for 17 years. I am now separated, but a lot of growth has happened in that separation time. And I will say that one of those was, okay, you may be thinking about new relationships now. What is the thing that worries you, Dawn? Me talking to myself, and it is how I've not had to tell another person for almost 20 years that I live with this condition that could be very challenging at times, that could be absolutely debilitating at times. How do I tell the person that? How do I describe it to them in a way that doesn't, I'm sorry, scare them off? And as we develop the relationship, how do I bring them in and show them how they can help and support me? Okay. So a lot of strikes against us, or strikes against our service recipients who may be thinking about romantic relationships as one aspect of sexual health. And I know I'm talking a lot about the relationship element, because that's how it comes out an awful lot when people start to talk about things, goals that they want in their life. So that might be your entree to talking to your service recipients or service participants about their overall sexual health. Maybe when that person is either complaining about the lack of a significant other or others in their life, or they may be talking about loneliness, and they start to talk about, wanting to have somebody to share experiences with, or, even developing friendships. That idea of disclosure may come up. So lots of things that make it challenging. Let's talk about what we can do to help individuals actually achieve sexual health, and the things that we all need as well. So some of the things as providers that we can ensure to help individuals achieve sexual health, or a greater sense of sexual health, whether that be gender identity, whether that be sexual, satisfaction with the actual act, whether that be, yeah, addressing some of maybe the functional concerns that could be side effects from psychotropic medications or other medications, or from simply having a behavioral health condition or other physical health condition. What are the things that we can do to shore up this aspect or this domain of an individual's life? Well, one of the things that I'm going to tell you is none of you have to be sexologists or or sexual therapists or experts about sexual health at all. I am not. I am just starting at this because it is a topic that fascinates me, because it is a topic that I see there is a lot of pain and injury around, just because our service recipients and we as a society don't have enough information. There are a lot of catastrophic effects of not having information, and some of them can result in death for individuals that we serve. So I want people to appreciate how significant sexual health is, because it really can have a huge impact on the lives of the individuals that we work with. But these are the kind of simple things that we can do for the individuals that we're serving and for ourselves. Make sure that individuals have access to comprehensive, good quality information about sex and sexuality, right? So again, this isn't just how to have sex, like the how-tos and what happens when we have sex, but also like the other elements, what it means to be sexually healthy, um, information about intimate partner violence, information about power and control dynamics that can happen in relationship, information about disease transmission and prevention, right? Information about coercion and sexual trafficking. Like there's a lot of topics that swim in the realm of sexual health. And so we want to make sure that the individuals that we work with who who are a vulnerable population and who may be targeted for things like sex trafficking, like sexual assault and coercion, um, that we are an exploitation, that we are making sure that they have information and access to this, and that they know the difference between consensual and non-consensual acts. Knowledge about the risk faced and vulnerability, we kind of just talked about that, to adverse consequences of unprotected sexual activity. So in our world right now, when I do my research and when I talk to people, especially younger folks and people of the Gen X generation, as I am, there seems to be a complacency around sexual disease transmission. We don't hear about HIV as much. We don't hear about AIDS as much. We don't hear about a lot. We probably hear more about HPV at this point. And HPV is important to talk about and for people to understand risks and ways to manage the risks and what to do if you have it, and the follow-ups that you need. But like, we don't hear as much about HIV anymore. And there is power in messaging. And I think that a lot of people have become very complacent. It is still there, right? And not only HIV, but things like syphilis and gonorrhea and chlamydia and, like I said, HPV. And these things are all still out there. And we just are not talking about them. And I think some of this is COVID overshadowing. We are just not talking about them enough. And this is something that we saw the folks in inner cities did a lot of outreach about 6 months into the COVID pandemic, because they started seeing some upticks in sexual transmission of infections. And we don't know. We don't know why. We don't know if people were just taking more risks because they were feeling stress, and so they were engaging in sexual risk taking, or if perhaps the messaging was starting to fail the public, that this is still there and it is still potentially life threatening or at least impactful. The ability to access sexual health care. And I am not going to talk about abortion. I'm not going to talk about decisions and what around. Well, okay, I will. Recently there was a decision that impacted the ability of individuals to access abortion as a medical service. Whether you agree with that decision or not, it's a limitation of a service that was there now, right? And so when we serve individuals, we need to understand that sometimes people are going to show up with sets of needs and with um, situations that they might find themselves in that may require us to help them. This may include family planning, right? And so we have to look at what are our feelings around things like abortion, contraception, simply talking about sexuality, sexual health, and topics that are related to it in general. One of the things that the Dobbs decision did do for people is create some reproductive care droughts and deserts, I'll say deserts in certain parts of the country. The coasts, maybe not so much affected, but we do need to know that that decision is going to take away a service that individuals had for almost 50 years, right? So whether you agree with it or not, it is an access point that is now no longer there or has been made more difficult for people. So also, if you're living in areas of the country that may not be as well populated as the coast, or as, in Seattle, you're going to have different access to a lot of different kinds of care than you would, and somebody help me out here, somebody in a more rural part of Washington. If we were talking about New Jersey, I could tell you a city in the Pine Barrens or a city in the county where Jennifer lives, and we would be good. But in Washington, I don't know your rural areas as well. But so we do need to realize that the access to sexual health care, things like family planning, things like disease prevention, disease testing, consultation and counseling, gender affirming services, things like this may not be as accessible. And so as we do, as good service professionals, we try to fill in those gaps, right? It's really hard in this area. And so, but there are a lot of resources out there, and I'm going to provide you with some of those towards the end of this webinar. And one of the most important things that we can do for the individuals that we work with is to provide them with an environment that affirms and promotes sexual health. Probably the biggest thing that we can do to promote and affirm sexual health as service providers is to be comfortable with terminology, to be comfortable with talking about sex, to be able to say the word masturbation without laughing, and I still sometimes do, to be able to talk about sexual acts. And I'm not saying that you need to initiate these conversations, but to be able to hear your service recipients talk about this personal area of their life and be able to sit with it. You may have to sit with discomfort. I still do at times. But, just to kind of gain that sense of comfort. And I think that we become more comfortable when we learn more, because we're not as afraid to not have answers for people or not know how to respond. And it's okay to say, I'm not quite sure I'm not quite sure how to respond here, and to get information for somebody or to tap somebody who is a better expert at it than you. That is not a problem. But what is important is to convey to your service recipients that you were open and that you were there for them to talk about not just this aspect of their life, but you want them to be able to feel comfortable with you, to have a positive therapeutic rapport so they can come to you about a variety of aspects of their life, right? Whether they're having difficulty managing their finances or whether they're having difficulty in their sexual functioning and maybe they want to see a doctor about it, or maybe they don't know that they can see a doctor about it. And you're going to be the person that helps them, and connects them to that service provider. So unless they feel comfortable doing that, and this is a especially sensitive area of our lives that we keep private, they may not come to you. Okay. So what are some of the really important or critical risk areas that we need to talk about with our service recipients? And please don't assume that individuals know about this stuff based on their age, right? We assume that people maybe who have a few more years of experience, a few more years under their belt may know how to protect themselves from sexually transmitted infections? Absolutely not. I've met 60-plus-year-old ladies, entering an apartment from a psychiatric hospital and finding themselves with in relationships with individuals and not knowing the ins and outs of how to protect themselves and not knowing when certain symptoms may be indicative of an infection, right? And so like we cannot assume that people know this information. So by having materials also that you can hand to people that are written at a digestible writing or reading level in the language of the person's preference, having Spanish materials for individuals whose first language may be Spanish. Things like this could be really helpful in providing people with information. Sometimes people don't know what they don't know, and we're not mind readers as well. But some of the most important risk areas that we need to educate our consumers, our clients on, are this idea of the transmission of infection. For a very long period of time, this is almost the only thing that research into sexual health and sexuality and sexual functioning in the population of individuals with psychiatric conditions focused on. We focused on what are the risks and controlling that risk. It was really a surveillance and control approach to the sexual health of individuals with psychiatric conditions. So as providers, as research, as academicians, we weren't so much concerned with people being healthy and happy sexually or intimately or romantically. And I'm sorry, I keep using the word sex, but intimately with other people, as much as we were making sure they weren't going to get hurt, that their condition, their psychiatric condition, wasn't going to be made worse by being a sexual being or by simply having romantic relationships, and that they weren't going to harm others. Now, think about all the stigma that's loaded into that, right? That approach to research was directly influenced by the stigma of our society, right? Sex is going to be too harmful for you. You're not ready to have a relationship. You're not well enough, and this is only going to be bad for you. And if you're in a relationship with other people, you may harm them. That was the message of the research. And so we've started just within like the last decade to see that shift. And I absolutely credit the recovery movement for that, the peer movement, psychiatric rehabilitation, because I think it's starting to have an influence on that kind of command and control way of serving people. So we need to educate people about things like HIV. It's still out there. We need to educate people about, and it's not just, right, like certain populations that can transmit and receive HIV. We need to educate people about other STIs, sexually transmitted infections. As I said earlier, certain things are still out there, and we don't talk about them as much because HIV was the heavy hitter and talked about for such a long time because it took so many people from us. Syphilis has also taken a lot of people from us. Chlamydia is still out there, right? So the gonorrhea is still out there. HPV is out there. And so we need to have these conversations, and also women and men who may want to at some point in their life. So if you think about maybe the transition age youth that you're serving, those folks are maybe like in the 18 to 20, my gosh, I want to say 30, but 18 to 24 kind of range, who maybe have not started thinking about having a family yet, but maybe they want to have children in the future, whether that means with another individual, whether they want to, raise the child on their own, whether they want, some of these infections can lead to reproductive issues. So even educating people on, these conditions that could lead to reproductive tract infections and cause sterility in men and women, pelvic inflammatory diseases and things of this nature, we need to educate our folks about, especially those, for people who might be thinking about having children in the future, biological children. This is something that we need to be aware of.
Hey, Dawn, before you go on,
Yes, ma'am.
There was a question, number one, from earlier, and Rachel, I'm sorry, I misread your question when you first asked it, but number one, why do you think other countries, like the Scandinavian countries mentioned earlier,
Yeah.
are more progressive and healthy regarding sexual health? And then Oliver chimed in with the statistics. The US have a quarter
Yes.
genital herpes compared to like 1/18, 1 out of 18 in Canada, and 1 out of
Yes.
20 something in Scandinavia. So are those things related?
Yes. Thank you. So Oliver answered my question, or answered Rachel or Rochelle. Is it Rochelle or Rachel? I want to pronounce it correctly.
Thanks.
So Oliver, you kind of answered the question. So here's why I say that. Do I know for certain that everybody in Scandinavian countries are more progressive? I don't know that for certain. I've never been, I'm partly Swedish, but I've never been to a Scandinavian country. So thank you, Rochelle. When you go to the research, when you start to research sexual health, you'll see research in the United States, that comes out of the United States. You'll see a lot of research also that comes out of Scandinavian countries. Scandinavian countries, what I have noticed by conducting systematic literature reviews, which are ridiculously long and boring, but I've had to do it for my dissertation, they have a much deeper and longer body of research in the Scandinavian countries. One of the reasons for that is because they have national healthcare systems. So when you have a national healthcare system, as they do in Canada, as they do in the UK, as they do in Scandinavian countries, you're able to better collect and track and analyze data. So you just know more, right? So they're able to produce a lot more research. So the universities over there and the sex researchers over there are really swimming in a lot of data that they partner with the government to then analyze, develop aha, moments, and they publish that. So one of the reasons is because the structure of their actual healthcare and health insurance system. Another reason is because of that reason. Well, what I'm going to say is another reason why I think they are more sexually progressive is because they have been involved in that research. And in the Scandinavian countries, they talk less about risk than they do in the United States and in even in the UK. So in Scandinavian countries, and I've even seen in Asian countries, researchers talking about the emotional elements of sex, the feel good, the how do we help people feel better and more satisfied in this area of their life, rather than commanding and controlling and restricting and hoping to prevent disease transmission and things like unintended pregnancy. That is what we focused on so much in the United States versus how do we help people feel better about this aspect of their life. I hope that helps. And also in the Scandinavian countries, there's more of an emphasis on, even when you look at things like substance use, harm reduction and others. So it's more of like, this thing is here. It makes us uncomfortable, yeah. But by talking about it, it makes our society, and obviously we can see that by the comparative data that Oliver, I almost called him Oscar, that Oliver just shared, that disease rates are significantly higher in the United States than they are in these other countries where they are more open, positive, and affirming about sexual health. It really does, Rochelle. It really, really does. Because if we don't talk about something, it seems taboo, right? And we're not going to ask questions, and we're not going to talk about it. And then members of our society are ignorant because we've imposed that ignorance on them by binding their mouths shut. So there's consequences. So sexual dysfunction. So individuals with behavioral health conditions and other physical conditions for which they have to take medications for, receive some other sort of treatment for, or just as an extension of the consequences of the illness, may cause things like sexual dysfunction. So the way this might show up for people with behavioral health conditions are things like side effects from medications. The number one, and this was actually a study out of Canada that I read for my dissertation, and I'm sorry, Jen, I just felt like Tom when I said that. I read an article once.
That's pretty funny.
We have a colleague that we pick on that reads a lot of articles. He's our boss, so we pick on him in a loving way. But the number one reason in a qualitative study that I read of 60 participants, and again, it's only 60 people, but 60 participants with major depressive disorder recurrent in men over the age of 65. The number one reason, it was a study of why people stop taking their meds, right? People have a lot of reasons why. The number one reason for men over the age of 65 being treated for depression was sexual dysfunction. So again, we can't assume that we're only going to need to talk to the younger generation about this stuff. But people are making this decision that sex is really important to them. That if physical, the act of physical sexuality, lovemaking is a part of their lives and it is valued as a part of their lives, very often people are going to choose that over taking a pill. And we understand as providers of behavioral health services, we understand that, but we also understand that's a slippery slope, right? Like, I'm going to stop taking my meds for about a week or so that I can engage and feel alive and feel present and have all my parts function for once, right? But also in that week period of time or whatever it is, maybe some of those negative symptoms start to creep in. And so we have to talk about these things up front. In another study, my gosh, I'm sounding like Tom so much. One of the reasons why psychiatric nurses and nurse practitioners gave for not wanting to disclose potential sexual side effects of certain psychiatric medications upon prescribing that medication to their clients is that if I tell them that they may experience sexual dysfunction, and that is not only limited to men, it's also women can have things like anorgasmia, which is inability to achieve orgasm or lack of libido as a result of some of these medications as well. If I tell them this is a potential consequence, they won't take the medication, right? Now, there's a lot of medications that could also have this side effect. Like I said, a lot of blood pressure, a lot of cardiac meds, some meds that help control blood sugar, things like this can have this side effect. And we don't talk about it because we assume people won't have the ability to make an informed decision. And I think that is just such a crappy, I'm sorry for the non-academic language, but just a crappy outlook. And wow, what a lack of respect and belief that people can make informed decisions just because they have a mental health condition, right? So, but we need to talk about this because there are things that can help if that negative side effect does happen. There are interventions that can be provided. Hopefully it's not another medication to put on top of it, but sometimes it is. We all know about Viagra. But that is a consideration. We want people to be healthy and happy in all aspects of their life. So they should be informed. I talked earlier about unintended pregnancy and abortion. Regardless of what side of the aisle you're on in terms of being pro-choice, being identifying as pro-life, being somewhere in the middle, just not having an opinion maybe. It is still can be a crisis situation for people, right? If they find themselves in a situation where they are pregnant or where their partner is pregnant and it was not something that was intended upon. It's a difficult situation, I believe. This is just to put my 2 cents out there, regardless of the side of the aisle, regardless about any of your spiritual beliefs or values that you have around when life begins and what, abortion, how abortion fits into that and what that means legally and spiritually and morally for you as a person and for others. It's going to be a stressful situation, right? If a person is faced with an unintended pregnancy and is thinking about all of their options and not just abortion. But individuals who have a serious psychiatric condition are at higher risk of unintended pregnancy and at a higher risk for, I shouldn't say risk, are overrepresented in terms of terminating pregnancies. So, so this is something that we need to be aware of, and need to be aware of the resources that are available to people. And again, not just for termination practices, right? Some people may choose to surrender a baby for adoption, or there may be, or may decide to keep a baby with supports and raise a child. And as a service provider, some of my most stressful times in my life, in my professional life, has been when one of my service recipients or their partner was expecting a baby. I had several females who were on some serious medication and had to, and chose to have the baby, and had to come off their meds or had to take other medications. And it was a really, really stressful time for them, for their fetus, for their significant others if they were in the picture, and for the care team, because there were so many decisions that had to be made. And even for one individual, she had to be hospitalized the entire third trimester of her pregnancy because a certain medication that she was taking, I believe it was for as a mood stabilizer, she could not take during her third trimester. And when she came off of it, she was a danger to herself and others. And so she had to be literally hospitalized for the end of her pregnancy. And nobody envisions themselves bringing a child into the world under those circumstances, right? So it's a lot to think about and a lot to have to be ready to address. Sexual violence and intimate partner violence. So, and I separate those out because the act of sex might be involved in the violence. It may not be. But we are talking about things like rape, like sexual trafficking, when we're talking about sexual violence, and issues of consent, and empowering the individuals that we work with to understand, especially because a lot of individuals that we work with have had the trauma of being victims of sexual abuse in their past, or they may have formed insecure attachments as children because of child abuse, and may then develop some tendencies to stay in relationships with people who are abusive longer than they should, to seek out those more challenging relationships because they're kind of following the pattern they were programmed for in their youth, right? We really need people to understand that, you need to define what is comfortable for you sexually, and you have a voice in saying whether or not you wish to engage in sex at any given time. And you also have a say in terminating the sexual act at any given time. It is true that you can consent to sex and then decide in the middle of sex that you don't want to have sex anymore, or that you don't want to engage in certain sexual acts, and you can ask to stop that, and it should be stopped, right? Some people don't understand this. And so, kind of having these conversations with people can be really helpful. And intimate partner violence. So intimate partner violence is that, we talk about domestic violence, specifically when we talk about intimate partner violence can be a type of domestic violence. And specifically, it's surrounding that intimate relationship, which sex may or may not, again, be a part of. As someone had asked earlier, does the actual act of sex always have to be a part of something? No. You can be intimate with someone. You can have a romantic type of relationship with someone. You may be exiting an intimate relationship, such as the case with situations of post-separation abuse, post-divorce abuse, stalking issues, things like that. These can be acts of intimate partner violence. And we need individuals to understand, how to report this, to lessen their shame around it, because there's often a lot of shame. And again, to just be that resource and to be that presence for them. And harmful practices. When we talk about harmful practices, you see the FGM next to it. That is for me to remember to talk about female genital mutilation. So things like harmful practices such as trafficking, which can also fall into sexual violence, but also things like female genital mutilation. This is more, there may be certain communities or subpopulations in the United States, cultural communities where this may be an element of their culture. That is not to say that it is allowed and okay in our society, right? We have laws against hurting people in this way. And if you don't know what female genital mutilation is, it's the act of removing all or a portion of the clitoris of the female so that she cannot experience pleasure during the sexual act. It is a way of confining what we think of as a male-female sexual act. And I'm sorry when I say that, I mean the heterosexual female act or heterosexual act of sex confined to only procreation, right? So it is a control measure that is taken that is born out of some spiritual beliefs and practices, and also misogyny towards women and subjugation towards women. So you will probably not see this crop up a lot, if at all, in your career, unless you're working with individuals who may be a part of a certain cultural population, right? Other things also, like arranged marriages. You may not see that as much because, let's face it, when we work with individuals, very often family isn't in the picture or isn't super involved. But this still continues. It continues in our country, and there's people who participate in it and are okay with it. But again, if an individual is not okay with it, genital mutilation is never okay. Not in this country. I'm going to take that hardline stance. But other forms of partnering and family involvement with kind of sponsoring that partnering, those are conversations that we have to be comfortable in having with people if that is a part of their culture, and if it's an expectation that perhaps their family unit, their family of origin may have on them. Okay. So I got so somebody sent a statement to me, and I'm just going to read it, and there's no names, so you're anonymous. And they say, as someone who experienced mental health issues and type 2 diabetes, and I'm going to raise my hand and say, me too. I have both, and hypertension. Open communication of sexual side effects and remedies has been a significant benefit to me. Absolutely, bravo. So without telling you too much about my sexual life, I will say one of the things that I found was I had negative side effects from a very commonly prescribed antidepressant. Not only did it affect the sexual aspect of my life, but I just kind of didn't want to do anything on this dose that I was on. Nothing bothered me. Nothing really fazed me. I never really I didn't really get to experience sadness so much anymore. Times when I felt like I should be mad, I wasn't mad. And times when I was supposed to be really, really, really happy, I don't feel like I was really happy. And there was this other aspect, that intimacy of surrounding that very specific act was difficult. And so having medical practitioners who are comfortable with talking to you about that is extremely helpful. And I will tell you, for me, it wasn't my psychiatrist who I felt comfortable talking to about that. It was my female nurse practitioner, who is also my OBGYN. And she is also the first OBGYN that I ever had ask me, are you satisfied with your sex life? Just right off the bat, she asked her patients that. And I think just being able to say that, now you're not going to talk to your support, you're not going to walk in tomorrow morning to see your next supportive housing client and say, hey, John, how's your sex life? You're not going to do that, right? But just to show you like how that issue was never even addressed by my psychiatric prescriber. But this other person who is comfortable, obviously, they're an OBGYN, but maybe not so obviously, because she's the only OBGYN that has ever asked me that question. And I've been on this medication for almost 22 years. And I see my OBGYN every year. No one's ever asked me that question, except for like, she was like within the last 5 years. So I really thank you for that response, because I think that shows how powerful it can be for us to be open with our clients. And I'm disappearing into my background, sorry, but to be open with our clients, and how much open communication can really help improve the quality of people's lives. Okay, and the end result of that was I reduced my antidepressant, no worse for wear, and I feel better overall in my life. So those things, it doesn't also have to be all or nothings, right? It doesn't have to be you take your meds and you're not happy in your intimate life, or you don't take your meds and you have a wonderfully fulfilling sex life. It doesn't have to be either or. Okay. All right. And so we touched very briefly on this aspect that stigma creates, internalized stigma specifically, called the spoiled identity. And this spoiled identity is, unfortunately, as what the research indicates, staff tend to think when they are asked about their service recipients and the topic of sex and relationships and dating, staff tend to focus on the things that can go wrong. Have opinions like people need to be out of the hospital for a certain period of time before they decide to date. They also, a lot of folks also have this opinion about things like getting back into the work world, going back to school, things like that, because I think we take on a protective role, and we want to protect the individuals that we work with from any kind of additional stress, right? You just got out of the hospital, or you just transitioned from the emergency shelter, and now you're in your own apartment, and we want to get you off to a good start. We want to make sure you're doing well. So let's not add another thing to the plate that I, as the service provider, feel ill prepared and unequipped to talk to you about and to help support you through, right? So it's more, I think, about that. But one of the things that research shows us is that despite us feeling like, and I'm just using the royal us or the royal we, despite those more negative or pessimistic opinions that we might have about the individuals that we serve and their ability to have happy and healthy relationships in their lives, service recipients are saying, I want my provider to ask me about this. Overwhelmingly, in the research that I have read and started to conduct myself, people say things like, I want someone to ask if I'm healthy, if I'm happy in my relationships. Do I have a significant other? Am I thinking about dating and developing relationships? As that discussion of the whole person. And, especially around service planning and around assessment times or reassessment times, it opens up the door to have that conversation with people. Like, looking at I would say a wellness wheel, or the different aspects or domains of people's lives, and asking them how happy they are in each of those. You don't have to ask about sex specifically, right? We can talk about romantic relationships. You're thinking about dating anybody, who are you spending your time with these days? Or you thinking about, we can have those conversations, and folks want us to. Just as I showed you, I wanted somebody to talk to me about the problem that I was having as a side effect for my antidepressants. I was too ashamed, even as a mental health practitioner of 24 years, too ashamed to initiate that conversation myself. As a person who's had a child, who at the time was married, I couldn't do it. Right, Jen?
I know we're getting close to the end, but there
That's
was a
fine.
question that came in about traditional 12-step programs often promote within the first year of recovery, there really shouldn't be any relationships. How
Yeah.
would you reconcile that?
Yeah. So I don't know if you attended our earlier training today. It was on process dependencies, and if you didn't, it was a good training, and that resource is out there for you. And I'm sure we'll repeat it. But we talked about 12-step programs, and they do really encourage people not to enter into relationships early on. When you're early on into sobriety, when you're still working that out, right? Or you're constantly working that out. But when you're early on, when you're new to sobriety, um, it is important to remember, and I'm not denigrating the 12-step process, because it has been a lifesaver for many people. And I think a lot of what we think about when we think about psychiatric rehabilitation and recovery in general has been born out of programs like AA and NA. So I give them their props, and I'm very thankful that they exist. But the thing that we need to consider is what feels right for the person. right? What feels healthy for the person? Knowing that for a lot of people, for me, for instance, when I have somebody that I feel connected to and that I feel like I'm in a loving relationship with, it's not just about the love, and it's definitely not just about the sex. It's about all those things that we talked about on that first slide. Remember that? The support, the communication, the just the antidote to loneliness, which for some people loneliness can be a trigger for substance use or abuse, right? Or other process use or abuse. Um, there are alternatives to 12-step programs. We did talk about one of them earlier today, something called Smart Recovery. And it is a nationwide program. If you Google Smart Recovery, you can find some information about it. It doesn't follow as many of those strict rules as the 12-step programs do. It is more rehabilitation focused, more recovery oriented, I think, in the way that we think about psychiatric recovery and looking at that whole person and acknowledging that we're all unique and we all need different things in our life. And for some people, having that stable relationship may help them in their recovery. Again, if it's healthy and positive. So I would say I'm not going to critique the 12-step program because I am not well versed in addiction and in substance and process recovery. But I would say it has to be a personal choice. And that is something where I think a sponsor, a good sponsor, could really come in handy for that person in recovery to have that conversation around. Okay.
Dawn, also, there was a question, is there a way to get the link to the earlier training?
You know what? I will check with our counterparts in Washington and see if maybe they can send out that link to folks who weren't registered. We may also be able to send that out directly. We could figure that out. But if you know what, I will follow up with Washington. I will take care of that.
Okay, thank you.
No problem.
And just to give you a heads up on time, I
Okay.
think we go till 6:30, right?
We go to 6:30. So
Okay.
I'm wrapping up now.
Okay.
In terms of what you can do, and this is going to set the stage for next week when we talk about actual strategies. So this is just kind of like priming your pump, getting you comfortable, and hopefully encouraging you to do a little bit of research on your own too, and look at where you are. How comfortable do you feel talking about sex? Does me just talking about it and saying different words like trigger something in you? And that's okay, because it does for me. I've had to practice saying some of these words an awful lot, but start to ask questions, not only of your service recipients, but of yourself, doing some introspection, like how comfortable do I feel talking about sexual health? How aware am I of facts, right? And so it may require us to do some of our own homework to be prepared. Identify the unmet needs that your individuals receiving services may have. A lot of people who experience psychiatric conditions, a great area of unmet needs are around, especially for females, their gynecological health, their feminine health. And so knowing that as clinicians, we need to be asking those questions and not ignoring that as an aspect of their health. In establishing goals and goal settings, not being shut off or thinking that when somebody says that their goal in life is to get married or to find a girlfriend or a boyfriend or several of them, that's not something that we can work with. We can absolutely work with that goal, but we can figure out ways to break it down so that it is meaningful, so that we incorporate rehabilitation aspects, skills building, and these sorts of things that will help along the way, that will build skills along the way towards that goal. To educate and link individuals to services. So as housing providers, as individuals who are going into the community and providing an array of services or having to meet the needs and an array of needs that people have, you're not expected to be an expert. You're not expected to be experts on everything, right? Or anything maybe, because you have to be such a jack of all trades. what you do know is you know your clients and you know how to establish that therapeutic relationship. And so using that therapeutic rapport to be able to educate or link individuals to other services that can educate them and help them is invaluable. And to advocate, 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 to come to trainings, to speak, to defend, those things are all important. And again, to provide that kind of positive and affirming environment. And I believe this is probably the last screen. So on the resource slide, I have several websites that are affiliated or that are sponsored by these organizations here on the screen. One of them that is very helpful is something called Sexual Health TV. I believe it's sponsored by either the CDC or the American Sexual Health Association, but it's really great, just very factual, and could be a great resource if you have individuals that you're working with that may have questions or concerns, that you could provide them with that resource, and or just simply learn for yourself. Okay, so in part 2, we're going to talk more about our attitudes that sometimes get in the way or make it more likely that we're comfortable with and willing to engage around sexual health issues for our service recipients. We'll talk about how we maintain our boundaries and our own sense of comfort in the therapeutic relationship while doing that, and how to actually engage in those conversations and some frameworks for having those conversations. And I think that is it. Now, if anybody has any questions or comments, I can stay behind for a few minutes, but other than that, we are wrapping up. And Jen, I don't know. Oh, the part 2 announcement should have been sent out. It will be, I was going to ask Jen if you could put our website in the
Yes,
chat. So Jen is going to put a link for our Rutgers Hour project, the State Hospital Psychiatric Rehabilitation Initiative, which has a lot of free resources on it. So you will find a lot of resources there, not many about sex or sexual health, but a lot of free resources there. I also need to say that we appreciate your time, your attention, your participation. And again, this webinar was hosted by DBHR through the Healthcare Authority. I'd like to remind you that the slides, a link to the recording, and a wealth of other resources will be made available in the follow-up email. And don't forget to check out the Foundational Community Supports newsletter for FCS information. And if you're interested in becoming a Foundational Community Supports provider, you can contact AmeriGroup at the number on the screen. So that's just a little bit of advertising that we're asked to do for FCS. And the time next week will be the same time as this week and on Wednesday. So yes, the announcement went out. I can, when I follow up with Washington, I can find out if they could perhaps reissue the announcement. But thank you all for attending. We appreciate it. Thank you for making it interactive. And that's that.
Thank you all.